Hi, I'm Dr. Syed Ahmed. Today we are going to be talking about MRSA, cellulitis, skin and wound infections. MRSA cellulitis we see commonly in the hospitalized patients, and that will require IV antibiotics. We will talk about different intravenous antibiotic therapy that we use in the hospitalized patients. If I would divide the skin and soft tissue infection and cellulitis into two categories, one without any open wound and cellulitis with open wound and drainage. Cellulitis, which is without any skin breakdown, usually caused by staphylococcus and streptococci, and the treatment is usually with cephalosporins such as cefazolin is usually the drug of choice. Cephalosporins don't cover for MRSA except for ceftaroline. Uh, in these cases, we initially give anti-streptococcal antibiotic, and if there is no response within 48 hours, then we upgrade the antibiotic therapy to include MRSA infection as well. In patients who are allergic to penicillin and we cannot use cefazolin, then clindamycin is the drug of second choice. Sometimes when pseudomonas coverage is required, especially in diabetic patients or patients who have punctured wound of the plantar surface of the foot by a nail, for example, in those cases pseudomonas coverage is required, and Zosyn would be a better option. In patients who have open wound associated with severe cellulitis and there's a lot of purulence, MRSA should be considered and treated empirically. Vancomycin, as you know, is the drug of choice intravenously, and the trough level of vancomycin should be maintained between 15 to 20. In cases where a patient has renal insufficiency or there's contraindication of vancomycin, then other options include daptomycin, 6 to 8 milligrams per kilogram per day, but the dose will need to be adjusted in cases of renal insufficiency with GFR less than 30 ml per minute. Other than daptomycin, as linezolid is sometimes used, and also ceftaroline in cases where MRSA is a consideration. MRSA should especially be considered in patients with a skin soft tissue infection, even without a skin breakdown, if the patient is septic or if the patient has prior history of MRSA infection or recurrent skin and soft tissue infections. There are numerous newer agents, FDA approved. One of them is fluoroquinolone called delfloxacin. Is used twice a day, but because of the cost, it's not widely used. Then there are other groups of antibiotics which are longer acting, and some of them have duration of action of 14 days, such as dalbavancin, but these antibiotics are very expensive. Other than dalbavancin, oritavancin has a half-life of 10 days and is used intravenously. Telavancin is another antibiotic, but is used daily, and this antibiotic can be used in cases of allergies to vancomycin, daptomycin, and when other agents cannot be used, but is very expensive. Skin and soft tissue infection with wounds and some necrotic tissues will require surgical debridement, and if there is an abscess that's drained by incision and debridement, and IND is already performed, then short course of antibiotic with anti-MRSA medications such as 5 to 7 days course may be enough for smaller infection. For more severe infection where more deeper tissues are involved, then the recommendation is for 14 days. And if there is deeper involvement of the muscles and neck fascia, for example, then in that case, 3 to 4 weeks of antibiotics are sometimes used. If the wound is open, then sometimes it can be probed, and if the probe reaches the bone, then it means there's bone involvement, which means osteomyelitis. And in those cases, 6 weeks of antibiotics should be used. To confirm osteomyelitis in a patient who has cellulitis with open wound, which is deep, MRI without contrast can be used, or bone scan is also very sensitive to rule out osteomyelitis. If the bone scan is negative and there is high suspicion, then MRI can be done to confirm the findings or otherwise. For smaller MRSA abscesses, less than 2 centimeter, if the incision and drainage is done as an outpatient, there may be no need for antibiotic if there is no surrounding inflammation or angry looking tissues. But if you see that the tissues are angry looking, there's a lot of inflammation, and the wound is more than 2 centimeter, then definitely needs follow-up antibiotic. Patient should be re-evaluated within 48 hours if outpatient therapy is given, because you want to make sure that there's no that there's a response to therapy. Now we are going to discuss about the antibiotics that we use intravenously for hospitalized patients. In cases of hospitalized patients with a skin and soft tissue MRSA infection, vancomycin should be followed by monitoring of the side effects such as Redman syndrome, renal insufficiency, cytopenias, especially thrombocytopenia, which can be early or it can be delayed for 4 to 5 days. Daptomycin, as you know, has other side effects such as rhabdomyolysis, especially in patients who are on statin therapy. Daptomycin can also cause interstitial pneumonitis, dyspnea, and non-specific cardiac side effects. CPK should be monitored while the patient is on daptomycin. Linezolid is widely used antibiotic, but it cannot be used for long-term therapy, especially for example osteomyelitis. First of all, it's bacteriostatic, and second, linezolid may be associated with irreversible neuropathy in cases when it's used for more than 4 weeks. Linezolid has been associated with thrombocytopenia as well, therefore CBC monitoring should be done while the patient is on therapy. Ceftaroline is an alternative, but it's rarely used, although it's available in most of the hospitals. It's used in cases where other antibiotics have either contraindication, such as allergy or side effects. This is all about MRSA skin and soft tissue infections. I will be back with more lectures on MRSA infection of other sites. Thanks.